right, so we have crossed over to the second part of this particular program, and this being Wednesday, we get into our health segment, and like I told you, the focus this morning is on cervical cancer, and we just want to break it down for you and to make it very simple for you to be able to understand. We'll go even into some of the symptoms and how this condition presents, and also take you through what you need to do in case you don't want to be part of the statistics, and if you're part of it, what are some of the options that are already out there for you to be able to explore. One thing we want to really emphasize is that it is preventable, and of course, if detected early, it is also manageable. So I have with me in studio Dr. Solomon Mutua, who is a clinical oncologist, and he's going to shed more light on what cervical cancer is all about. Thank you so much, Daktari, for once again creating time for us this morning.
Thank you very much. I'm glad to be here.
All right. So we usually, on this platform, we usually start by the very basic. And when we talk about cervical cancer, essentially, which part of the body is more at risk? Run us through that part of the body and how cancer affects, the cervix.
Okay, so starting with the basics, what is the cervix? Okay, this is an anatomical structure in the female body, and zeroing down into the female body, it's part of the lower end of the uterus, which is the womb. So it's like the doorway or the gateway into or out of the uterus, all right? As we all know, any part of the body can get cancer, okay, except the hair, nails, and teeth. Okay, so cancer of the cervix is one of the common cancers that can afflict a female. Okay, yeah, so the cervix is mainly a female anatomical area, which is the lower part of the uterus.
Mm-hmm.
Yeah. So
when you say cervical cancer, in the simplest term, what would you describe this type of cancer to be as? And it's very common among women. Talk to us about what it is essentially.
Yeah. Generally speaking, cancer is a disease of abnormal growth. Mm-hmm. Okay, so when you have abnormal changes in the body that lead to abnormal or out of control runaway growth, then this can lead to development of malignant cells. So when you're talking about cervical cancer, it's basically a situation whereby something triggers abnormal growth of cells of the cervix, leading to the cervix developing tumors that affect the human body. Mm-hmm. Yeah, so cancer is basically a disease of abnormal growth.
Mm-hmm. A disease of abnormal growth. But then how can one know or suspect telltale signs, the symptoms? How does it present?
The unfortunate story about cancer is that most cancers, when they are early and when they can be easily cured, they have no symptoms. So most of the time you find someone can be walking around with a cancer for years without knowing that they actually have cancer. Mm-hmm. So that's an unfortunate thing about most cancers. Okay, so, and cervical cancer is no exception. If someone has an early sign or early disease, then most of them have no symptoms. So for most patients, by the time they start getting symptoms, then you find this is a cancer that has become what we call locally advanced. It has started growing bigger and causing symptoms, or even advanced, meaning that it has spread from the cervix to other parts of the body. But when someone gets these symptoms, then these symptoms are, the most commonest is abnormal bleeding. Okay, we all know that a female usually has what we call normal menstrual cycle, which is normal bleeding, and most ladies, this is a predictable event every month. Mm-hmm. So when someone gets bleeding that is deviating from this pattern, yeah, then always they need not ignore this. Another common symptom that we see is abnormal discharge, and most of the time you find this is a discharge that mostly clear but has a characteristic foul smell, right? Some patients would have bleeding during sexual intercourse or even pain during sexual intercourse. Some patients would have constipation or burning sensation when you're passing urine. And then some patients, especially when the tumor is quite big and going into the nearby structures, you find that they will develop pain in their legs, lower limbs, or even swelling. Some patients can have low abdominal pain, and characteristically, this is a pain that usually radiates to the back. Okay, and then once the cancer now has become advanced, meaning it has spread from the cervix to other parts of the body, what in medicine we call metastasis, then the symptoms here will depend on which organ or which structure in the body has been affected. For example, if it spreads to the brain, then you can have headaches, convulsions, collapse, lack of speech or something like that. If it goes to the lungs, then you can have chest pains, coughing, difficulty in breathing. If it goes in the liver, then you can have abdominal distension, right-sided abdominal pain. There's something in medicine we call jaundice, where you get yellowness of the eyes. It can also spread to the bones. This can present with bone pains, even fractures. So it can spread to any part of the body, and once it's advanced, then you find that the symptoms now will depend on what part of the body has been affected. Yeah.
I wanted to talk about bleeding and the discharge that you mentioned, because there are other factors that could lead to that as well that may not necessarily be cancerous. Just take us deeper into that. For how do you discern, to know the difference? Based on the fact that there are other factors that could lead to a woman having.
So here I think the biggest take home is to have healthy health-seeking behavior in our population. All right. So if a woman feels that this bleeding is not normal, then you see it's incumbent upon herself to present to her nearest health facility. And once you present there, then of course the clinician will take history, just interrogate you, get to understand when it started, the pattern, when is it occurring, and then importantly, usually an examination is done. So most of the time the clinician will do a vaginal exam, or what we call also a speculum exam, just to inspect the vagina and also the cervix. And you see, with this direct visual or clinical inspection then can lead to a determination of what it could be. And if need be also, the clinician would always go ahead and do some other investigations like scans. You'd have your ultrasound scans, your CT scans, so any scan can be done. So apart from clinical examination, then imaging can be done just to ascertain what the problem is. But the biggest take home is present yourself to the nearest health facility.
In terms of numbers, how common is it? And I'll also like you to talk about, because of the delay in even noticing the symptoms, are we having a challenge of catching this cancer early, especially in Kenya?
In Kenya and third world country, it's pretty common. It's a common cancer. It's not the common. The commonest for women is breast cancer. Okay, this is the most common cancer. In Kenya specifically, cervical cancer comes number 2. But when you look at mortality, then you'll find that cervical cancer trumps breast cancer. So despite being number 2 in terms of prevalence, then you find that it is more lethal. And
it leads to more deaths.
More deaths than
cancer-related deaths among women.
So it's quite a common cancer that we see in our clinics, and we've developed quite a lot of experience, and we know how to treat it effectively, but the outcomes usually depends on when we get it. A very important thing, and I know we'll talk about this as we continue with our discussion, is in Kenya, in Africa, in the world, we actually have an opportunity to eradicate cancer of the cervix. And this is mainly because of the vaccination, which we'll discuss later. So it's so unfortunate that we are having a cancer that is a #1 female killer, and yet we have an opportunity to eradicate it, you know, yeah, so.
The irony that is there, yeah. But then again, do we look at the numbers we have as the real numbers, or there could be a much bigger problem that we are yet to deal with because of the lack of diagnosis, of even testing, the numbers who are turning up? In Kenya, people go to the hospital when it's too bad, like they can't take it anymore. Yeah. So could we be dealing with a much bigger problem, bigger than we've even discovered as a country in terms of numbers?
I think the biggest undoing and where Kenya is placed as a disadvantage, and this is also the story in most developing countries, is late presentation. Okay, first we're already starting at a back foot because when it's early, it has no symptoms.
Yeah.
But you'll find that when someone gets these symptoms, most of the time people just sit back, you know. You'll be amazed at how much people would endure and just carry on with their business and ignoring some symptoms. And as you're rightfully saying, people come when things are getting out of hand, most presentations. And it's a mind thing, I think. And that's what I was saying, the biggest take home would be health-seeking behavior. So whenever you notice something is wrong, it's incumbent on the individual to present early, and because early presentation gives us an opportunity to tackle this disease when the battle can be won, and usually the battle is won when we get these things earlier.
Or ideally just have like the annual checkups that are usually very advisable.
Yes.
Yeah, like for instance, for cervical cancer, like how regularly should a woman you know do these checkups?
Yeah, so this is now what we term as screening.
Yeah.
All right. And screening generally is looking for early cancer or changes that may lead to cancer in an individual without any symptoms. So you get your normal, well or seemingly well individual, and you do certain tests that can lead to detection of a pre-malignant or a cancerous state. And the most important thing about screening is that it enables us as clinicians to catch a disease when it's early. And when it's early, this is the time that you can actually make an impact in saving the life of this patient. Out of all the cancers that we have in the world, sadly speaking, only a handful are screenable. You know, again, another very unfortunate story about cancer. And these are, as we're speaking today, cancer of the cervix. We also have cancer of the prostate, cancer of the colon, cancer of the breast, and to very heavy smokers, cancer of the lung. So you'll see just around 5 cancers out of the many cancers that we have. So when we zero into cancer of the cervix, screening actually should be done in women who are sexually active, okay? And for women who are sexually active, you find that the international recommended age to start your screening is from the age of 21 years, okay? And the interval usually is broken down depending on what tests you're doing. So usually we group them between the age of 21 to 30. And during this age, usually what is recommended is a pap smear, all right? And the interval is every 3 years.
Every 3 years.
Every 3 years. I've met many ladies who tell me that they do a pap smear every year. It's not really necessary. If you've done a pap smear and it's okay, everything is okay, then you only need to do it after 3 years. Once a lady gets to an age, at the age of 30, then there are 2 options. You can either do a pap smear once every 3 years, or there's something we call co-testing, where you do a pap smear and a HPV test. And if these are all clear, then the interval is elongated, where you just need to do this every 5 years.
Every 5
right?
years.
There's a caveat when it comes to women living with HIV and AIDS, and because of their immunosuppression, then these are women who screening pap smears are encouraged every year, okay, because they're a bit of a special group of people. So again, you may wonder, what is this pap smear? All right, what is this HPV
Before
testing?
we get to the HPV testing, something I caught you say is that the target group is women who are already sexually active. I'm just keen to know, why is this the case? What is unique about this demographic that makes them, you know, a unique group for testing for this?
Okay, I always get people surprised, especially when I'm talking to ladies, just educating them and everything, and telling them that cervical cancer is mostly, almost exclusively, a sexually transmitted disease. And they always get surprised. They're like, sexually transmitted cancer? Yeah, and this is because of the virus called HPV. HPV stands for human papilloma virus, and this is a virus that exclusively infects human beings, right? And it's a very highly transmissible virus, even more transmissible easily than HIV and AIDS. And most of its transmission is through sexual contact, and that's why mainly you want to screen individuals who are sexually active, because the biggest risk factor of cancer of the cervix is through sustained infection of HPV virus.
All right, so I needed to know also, when somebody comes, for instance, I walked to the Nairobi West Hospital, concern has been how this test is done. People think it's very invasive. You know, what happens? What should a patient expect if they walk in to get a check? What should they expect? How is it done? Just to sort of like safeguard even their dignity.
Thanks for this question. And I think screening is, we can never overemphasize it. And in Nairobi West Hospital, this is something that we usually fully embrace. So and usually have different screening programs there as well. So when a patient comes, of course, they'll talk to a clinician, usually a nurse or our gynecologist, and they'll be taken, a bit of education will be done about the procedure, just to explain to them the expectations and just to get them comfortable. And historically, how this has always been done is, of course, it's in a privacy of a room, well enclosed, and the patient always lies on their back with their legs in what we call a lithotomy position, all right? And during this evaluation, first the gynecologist will inspect this patient just to see if there are any obvious signs of abnormality. And there's equipment called a speculum, which is inserted into the vagina just to help visualize, to open up the vagina, because you know the cervix is quite deep, high up in the vagina. And this speculum enables the clinician to clearly inspect the vagina and the cervix. And then the equipments that are tailor-made to collect samples, like a very small fine brush that brushes around the cervix to collect cells. And these cells are actually taken for evaluation of these cells, and also the stem tissue on request can be used to test for the HPV virus.
Because of what you have described, some find it a bit invasive, and many people would shy away from going for that particular test. So what is being done to encourage, you know, more walk-ins of people to come and test? Because part of the strategies to address cervical cancer is getting more people to come on board and get tested so that it can be detected early. But how do we encourage the numbers to go up?
Yeah, and as you're rightfully saying, numbers are always good because you're looking at an impact to the public at a public health scale. And again, rightfully, usually, especially the first ever intrusive evaluation to any woman, it would be very uncomfortable, and most women usually have to really psych themselves to come for this for the first time, okay? But you'll find that historically, the more they do it, it becomes more of a routine, and slowly they get used to it. But what has been done in Kenya and globally is a self collection or a self-test kit. Okay, this is an equipment that a woman can use either in the health facility, like at Nairobi West Hospital, or even at home, all right? And usually it's a very easy, I'll call it like a brush to use. Usually a lady is shown how to use it, because as you open it, one caution is to make sure that you don't contaminate it, you don't touch the areas that should be used to collect the sample. And they are educated on what position to assume that is comfortable to them. And usually it has either a mark or some wings that guides you how deep
it can go.
You should insert it. And the main difference with this kit is that whereas the pap smear gets tissue from the cervix, this usually gets tissue from the vagina, all right? So once a lady inserts it, they're advised on just making a circular motion for around 10 to 30 seconds, so that to ensure that they collect enough cells from the vagina, and then they retract it and safely return it back to its storage and present it to the health facility. And this has been shown to be as accurate as a clinician getting samples from your cervix. So this has mainly, or it's mainly aimed to increase that comfort and therefore increase the availability of women presenting themselves for screening. Yeah.
Because it's a new development, how is the trend picking up? Are women preferring that over the walk into hospital to get their test done? Yeah,
obviously, we all like our comfort, and a woman would be comfortable with themselves. Yeah, and this is something that has shown trends that it will actually help increase the uptake of screening, which globally and even locally has been an issue, but more of an issue locally in the third world countries.
I want us to talk about what happens after the test, but before we get that, because that then would take us to the different types of, the stages and what is done in terms of managing and treating. Let's talk about the vaccination.
Yeah.
Preventing cancer.
Yeah.
There's a vaccine to it. You said earlier that despite the fact that we have a vaccine to this particular cancer, we're still having many people dying as a result of it. So let's talk about that vaccine and, how it's administered and even the uptake and what it does and, what needs to be done to encourage the populace to take it up.
Yeah. Over the years, we've had so many illnesses that have plagued humanity, all right, from your plague to polio, and we've managed to kick out polio out of Kenya. There was always a campaign, kick polio out of Kenya. And right now, if you get an index case of a polio, it's taken as a big deal.
Yeah.
And the issue with cervical cancer is us as humanity in the future, we can actually get there. Cancer of the cervix is a cancer that can actually be eradicated from humanity, from planet Earth. And the biggest game changer here would be the HPV vaccine. And we are lucky with cancer of the cervix that we have a vaccine that can actually help us eradicate, prevent cancer. And this is mainly the HPV vaccine, all right? So this is a vaccine that should be given before, just to give you a perspective, HPV virus is not just one virus. We have around 200 different strains, but out of these 200, you have a few that are high risk, okay, in causing cancerous and other benign illnesses in the human body. So this virus targets the very common cancers so that it can have a global or public health impact in preventing these cancers. And just as we said, HPV is a sexually transmitted disease, then it goes without saying that your target population, ideally the best target population should be before sexual debut. So these are your children at the age, the best time to vaccinate is from the age of 9 to 14, okay? And again, both genders need to be targeted, both males and females. And the good thing about this vaccine is it kills many birds with a stone, okay? Because it will not only prevent an individual from the cancer of the cervix, but think about human body structures that are involved in sexual intercourse. So you have the cervix, you have the vagina, you have the vulva, you have the anus, and you have the throat because of oral sex. So this vaccination actually prevents an individual from cancer of the cervix, cancer of the vagina, cancer of the vulva, which is the external female genitalia.
So the HPV also causes cancer in these other parts of the body,
it can
the ones you're listing?
Yeah, it can cause cancer of the cervix, vagina, cancer of the vulva, cancer of the penis, cancer of the anus, because of men and women who have anal sexual intercourse. And also there's a part of the throat called the oropharynx, which is also affected by HPV related, associated HPV virus. So by just this one bullet, we can actually make an impact in all those cancers.
You mentioned something about the boys also being targeted for this vaccination. That is not common currently in Kenya. We're just vaccinating girls.
And there's a reason for that, all right? It is true, cancer of the HPV vaccine would prevent boys, because ask yourself, which cancers are we targeting in boys? This would be your penile cancer, anal cancer, and the throat cancer, okay? And while you're vaccinating this boy child, you're not only protecting him, there's something we call herd immunity. So by immunizing a few sample of the population, you'd be reducing the circulation amount or number of HPV, and therefore you'll be preventing, you'd have what we call herd immunity, which protects a bigger mass of people. So the boy child has been left out because of reason. And the biggest reason is that we are a resource-constrained country, all right, third world country. And when resources are constrained, then policymakers sit down and look at which group of individuals would we target that would have the greatest impact in terms of public health scale. And this has always been shown to be the girl child, okay? And they started from the age of 9 to 14, okay? And this is with reason. But if resources were not constrained, then of course policy would embrace the boy child as well. However, I've seen in media that government is still lobbying for more doses, because it's all about the doses, and most of these doses come as donations and foundations and everything. So they've realized that the boy child also needs to be brought on board, and if plans haven't started, I know they're on the way. They're
on the way. Yeah. You've said 9 to 14, but can anyone get the vaccine at any given point?
Yes.
Yeah?
So 9
even
to
beyond 14.
Yeah, 9 to 14 is your recommended, but there's what we call catch up. You can always catch up with what you missed in the future. And initially, and you see science keeps on evolving, all right? And initially there was a catch-up allowance to up to 28 years of age, but even now, even as high as or as late as 45 years of age, someone can still go for vaccination. The fact whether or not they are HPV positive, notwithstanding, that shouldn't discourage anyone, because someone can be infected with one strain of HPV, but the vaccine covers you from a number of strains. There are different types of HPV vaccine, 3 main types globally, but I think Kenya we only have 2 types. There's one we call a bivalent, and this usually gives immunization against the 2 commonest high-risk HPV strains. We call it a bivalent vaccine, or cervix. We have another one that covers you from 4 commonest strains. We call this the quadrivalent, or Gardasil 4. Okay. And then we have another one that covers you from 9 strains. So if you ask me, the 9 strains would be the best to have, but locally I think we have only the bivalent and the quadrivalent.
All right, so let's talk about after this, the screening is done and the tests are done, what usually happens? And this will take us into even the different stages of the cervical cancer.
Yeah, so once the screening is done, of course the vaccination would be to prevent. So screening is to enable us to catch it early. So once it's caught early, or there are abnormal cells from a pap smear that are showing precancerous cells, then usually they are, of course, if it's a nurse that has seen this patient, they would channel them through the right clinical channels for proper evaluation and further tests. And some of these tests, apart from clinical vaginal examination, the gynecologist usually can do something we call a colposcopy, where a patient is taken to theater and proper evaluation is done. And if abnormal cell growth, a tumor, is seen, then usually the gold standard diagnosis is a biopsy, where you now take tissue from the cervix and it goes to the lab to establish, 1, whether this is cancer or not, and 2, what type of cancer it is.
It is.
Yeah.
So once you get like a positive diagnosis, what are the stages and what is the severity of one stage vis-a-vis the other in terms of management?
Yeah.
What are the options?
Okay. So in a very easy breakdown, most cancers are staged into stage 1, 2, 3, and 4. And that 4 usually brings a lot of fear to patients. And patients always ask me in my clinic at Nairobi West Hospital, so, Daktari, what stage am I? You know, people are always interested to know what stage it is. So staging is basically a way for us to know the extent of this disease. And as you know the extent of the disease, then as an oncologist, I know how to treat this disease, because most of the time you find we segregate our different treatment modalities depending on the stage. All right. So, and the cancer of the cervix, you'll find that your stage 1 is broken into other sub-stage, the same as stage 2, 3, and 4. But what stage 1 basically means is a cancer that is very small and still located in the cervix by itself. It hasn't gone into the nearby structures. And as it starts growing in size and growing into the nearby soft tissue, then it becomes your stage 2, all right? And then it can start going into the vagina, all right, or into the, affecting the urine tubes, then this would be your stage 3. And then now, if it starts affecting your bladder or your rectum, because these are all neighboring structures in the pelvis, then that would be your stage 4, what we call stage 4A. And then once it has spread to distant organs, your brain, your lungs, your liver, your bones, or lymph nodes in the abdomen, then this would be what we call your stage 4 disease. So staging is just
how far it has gone.
How far or how extensive this cancer has gone. And usually the main importance is to guide me as an oncologist to know how to treat this patient. And also it helps me counsel this patient about our foreseeable journey of how well or what our levels of success would be in tackling this cancer.
All right. Because we're talking to a population, some have been made to believe that cancer is a death sentence. When it comes to cervical cancer, you've gotten that positive diagnosis. What are the options on the table?
Yeah. So usually...
And is it a death sentence?
Contrary to majority opinion in the world, cancer is not a death sentence. Of course, no one would want to have cancer, okay? It's not a good thing to have. That C word usually scares quite many people. But the world has really advanced to a level whereby cancer is now not a death sentence, all right? And especially when we get it early, then you find that our chances of curing are very high. And the earlier we get this disease, let's say a patient in stage 1 disease is easily curable, or the risk of recurrence is lower, as opposed to a patient with your stage 2 and stage 3. But usually when you get to stage 4 disease, you find that, unfortunately, is that every effort usually is made to control this disease and not to cure. But for your stage 1, 2, and 3, usually cure is there on the table. Only that the higher you go on the stage, you find that the risk of treatment failure or recurrence in the future is usually higher, okay? But cancer is not a death sentence. It doesn't have to be a death sentence, right? Yeah, so when a patient walks, for example, in my clinic at Nairobi West Hospital, what we start by taking history, okay? You need to know what symptoms the patient was having, for how long. You want to ascertain what risk factor could be causing this. And then, of course, you'll do a clinical evaluation. You have to examine the whole body of the patient, system by system, and then you zero into where the problem is. And in this case, it will be the cervix. And by doing a vaginal exam, already I can start getting an impression of what stage this cancer is, and already in my head I'm thinking of what needs to be done.
All right.
Once I do the examination, then I will send this patient for investigations, and here I'll need to do their blood works, and especially importantly HIV test, because there's a usually big correlation between HIV and cancer of the cervix because of the suppressed immunity of these patients. So that is one test that is very important to be done in these patients. And then other than that, we do imaging. And here imaging, depending on where someone is practicing, could start from as simple as an ultrasound or a chest x-ray, okay? But because of clinical advancements, we at least need an MRI or a CT scan. So we scan the whole body usually. You can do a CT scan of the chest, abdomen, and an MRI of the pelvis. And right now, we have a scan called a PET scan, which is very important in staging and treatment and evaluation of cancer of the cervix. And at Nairobi West, we are proud to also mention that we have a PET scan that really helps us in the fight against cancer and against many other cancers. So you'll start with your clinical history, physical examination, and then your blood works and imaging modalities.
All right.
Yeah.
It's good that you've taken us through, you know, even the advancements that we have had as a country, just to be able to catch this early and to manage it, because we are coming from a time when people didn't even know what cervical cancer is, and we were operating out of lack of information and lack of services. And we really appreciate your time this morning, Daktari, for just coming and shedding light. Unfortunately, that's how we just want to end it on that particular note. But a challenge to you: take care of yourself, You can actually just walk into the nearest health facility and get checked if you haven't done it in the last 3 years. And one thing I've learned, you don't have to do it every year. Actually, after every 3 years, you can actually get your test done. And good developments also that you can actually buy a kit or get a kit from a health facility and do it in the comfort of your home in case you're having concerns about the nature of the tests that are done within the health facility. My name is Safina Shengoma. Thank you so much. I have been engaging Dr. Solomon Mutua. He is a clinical oncologist from the Nairobi West Hospital right here in Kenya's capital, Nairobi. And also, we really appreciate your time and company since we began the show at 6 a.m. in the morning till now. Asante sana for keeping it daybreak this morning. That's how we wrap it up. Thank you and enjoy the rest of your viewing.